patients and have patient satisfaction. And we as doctors, want to be accountable for what our skills are, what the quality is of what we do, and evaluate and constantly evaluate and improve our judgment. Medicine's a little bit different today. I had some good conversations with people here in Bermuda, just like in Bermuda in the United States. It's not just the doctor-patient relationship anymore. We've got a lot of other stakeholders in the mix. We've got the concept of shared decision-making. We've got other stakeholders, hospital administrators, payers, employers, technology, AI, and telemedicine that all have changed a little bit what that core doctor-patient relationship is. But as we think about problems today and we think about our challenges, I think we can't lose sight of that. And so I want that to be an overriding theme for tonight's discussion. Some of the things that I think about today when we think about patients with spinal disorders are access. We have a hard time making certain that we can see all the patients who are having spinal problems in a timely fashion. And that's an important issue. And we as physicians need to play a role with our administrator colleagues to solve those kinds of problems. One of the other issues that we face is that we are constantly feeling the pressure to, do as much surgery as we can, but a lot of the patients that we see don't need surgery. And so there's triage challenges there. But again, this is something that's an opportunity for us to participate and try to help with patient selection. You could talk to any physician with experience, and I think the number one thing that people will say is that the ability to select the right patient for the right treatment is ultimately the challenge. And that's not something that you necessarily learn directly, at least in medical school. That's something that takes a little bit of time to understand. We also live in a world where we've got to think about the cost of what we do, the cost of implants, the cost of the technology used to do the treatments that we want to do. We've got to be mindful of that. We've got to be prioritizing that. And we also, in the spirit of being accountable, we need to look at the surgeries or the treatments that we offer to patients and what works and where our failures are. And how do we learn from those failures? How do we learn from patients who have one operation and then need another operation and then need another operation? And as we look objectively at it, we're not convinced that they're really better. So I want you to try to imagine a world where we go from this somewhat outdated concept of just a doctor and a patient determining everything that's going to happen to involving the rest of these stakeholders to improve actually what we do. Now, one of the topics I'm going to talk about is a big deal. Low back pain is a huge problem, not just in North America, but all over the world. It is a very costly problem. We estimate in the United States that we spend $200 billion a year on low back pain and its disability. Now, $100 billion of that is lost productivity because people can't work when they have such a serious back problem. And, as we look at primary care practices, one of the number one reasons to see a primary care physician is an acute back episode, acute back problem. And so it's a common problem for all of us, I think, in this room. If you look at the overall cost of spinal disorders in the United States, it is comparable to the overall cost of cardiology care and oncology care. And that is somewhat staggering for people because people are not dying from spine problems, but they are disabled from spine problems. And that's why I want to have the opportunity to talk a little bit about that with you. A little word about Lahey. Dr. Susan Moffett-Bruce is our president. She's here today. And I think one of the things that at Lahey is very important to us is collaboration. Is all of us, just like we're all physicians in this room, we work together, we collaborate together to try to get the best for patient care. And that is also the case in spine. From our nurses who are helping to triage our patients to our advanced practice practitioners who are working with us to help evaluate those patients, non-operative spinal specialists, hugely important. Had a great conversation with a chiropractor in the room. We need to make certain that we're getting the patients who are going to benefit from non-operative care to non-operative care. And we need to figure out how to do that in the best possible way. Interventional radiology, hugely important in terms of helping us to treat fractures and helping us to treat a whole host of problems that don't necessarily need a major surgery. And of course, spine surgeons. And we work together with all of these people at Lahey. So who are our specialists at Lahey? Some of these people, some of you in the room know. Rob Whitmore runs our surgery program. Subbu Bagay has been at Lahey for 30 years, seasoned specialist, takes care of a lot of patients from Bermuda, runs our spine fellowship program. Andrew Yu, spinal deformity surgeon, helping to fix people who have severe deformities of their spinal cord and spinal column and get them standing up straight again. Recently, we just brought Dr. Brenda Lee, collaboration between anesthesiology and neurosurgery, a specialist in non-operative care, and I'm going to get to some of the new techniques and new technologies that some of these non-operative specialists bring to spine care at Lahey. Also, Shola Akinroy, focused on the non-operative care of spinal disorders, and Neil Patel, one of our interventional radiologists, really focused on treating patients with fractures. All of these supported by our advanced practitioner service to provide a comprehensive care to spine patients. Now, one of the other tenets at Lahey is a real focus on data. We've looked at how we triage patients, how we try to get the right patient to the right doctor. One of the things that we've learned in the process of collecting data around this is that we're actually able to lower the cost associated with the workup of patients by getting the right patient to the right doctor. One of the worst offenders, if you look across the country in the United States, are neurosurgeons and orthopedic surgeons who order a whole host of tests for every patient that we see with a spinal disorder because it's what we do. But when patients see people who can focus in on the history, focus in on the problem, they don't necessarily need to get as much advanced imaging and can get a very good solution for patient problems. So reduction of cost, really important by collecting data. We've been committed to understanding the outcomes of patients from a health quality of life perspective. So what happens and what means things to patients is what we want to really measure and focus on. And we're showing that we improve quality of life and we also reduce disability. We get people back to work. And as we've looked at our data and we're constantly trying to improve what we do, 70% of the patients that we treat who were working before they had their injury or their problem, we get back to work. That's important in terms of reducing the overall cost of spinal disorders in our society. And we importantly get people off of opioid medication. Hugely important in terms of public health. So today I'm going to talk about a few things that are somewhat mundane spine problems, cervical myelopathy, back pain. We're going to talk about some modern concepts of how we deal with digital medical data and how we get to a place where we're using the data and the information that we can gather from our health record to improve the quality of the care that we deliver. I'm going to start with a case. It's always better to start with a real patient. This is a 55-year-old dean of a law school in Boston, active tennis player, was having some tingling in his right hand, and when he went to see a dentist, he had zingers going down both of his arms and was sent to see a neurologist. And the neurologist did a physical examination, a neurological examination, and saw pathological hyperreflexia, Hoffman signs, but overall good strength. And if you look at his MRI that you see here, you'll see that he's got compression of the spinal cord at 2 levels in his spine, at C4, C5, and C5, C6. And the level of compression at the C5, C6 is worrisome because there's a little bit of cord swelling at that area of compression. So a highly educated dean of a law school wants to get more than one opinion, which is always wise. So he got 4 surgical opinions. And what's perhaps understandable to all of us in this room, that different people see things differently, for people outside of medicine, this is really disturbing. This is a variation in care that's not trivial. If you look at surgeon number 1, laminoplasty, okay, smaller operation. Surgeon number 2, a fusion from the front of the neck and the back of the neck. So this dean of this law school looked at that and said, wow. So he went to New York to get a 3rd opinion and get yet a 3rd surgical opinion, decompression of the back of the spine no fusion, no screws, no rods. And then he went to see surgeon number 4, who said do a fusion at C4, C5, and C5, C6. All completely different. And I would submit to you also that if you look at the literature on this, a very different complication profile, a very different cost profile. But the key message here is variation. Okay. So I happened to be surgeon number 4, and so he stayed at Lahey to have his operation. But the question that I asked my mind was, this is the operation that we did, is this the best operation for him? Does anyone know what the best operation is with all of this variation in care? Does it matter? And what about the cost? So that's kind of the basis for looking at some of the things that we've looked at. If we look at the literature on this, Michael Phalings, who's out of Toronto, has done a lot of work internationally, gathering data in a prospective fashion to look at patients with spinal cord compression. And he's shown, I think quite convincingly, that surgery is effective. Even patients with mild spinal cord compression, where they've got good strength, but like this dean of this law school, were having some tingling in their arms when they were playing sports, they improve and can get back to the things that they really enjoy. But there are complications from this type of surgery that are not trivial. 12% of patients who have an operation from the front of their neck have a complication. Almost 20% of patients who have an operation from the back of their neck have a complication. But as you look at these data, these populations are not really comparable because the people who are having operations from the back, by and large, were sicker, had more levels of surgery, and were older. So we thought, let's look at this, and let's try to get doctors together from different parts of the United States, as well as internationally, and do a pilot study and look at this condition from the perspective of a patient. And I'm going to illustrate to you what I mean by that. If you look from a surgeon's standpoint, and this perhaps explains why there's so much variation, okay? The myelopathy, the things that we're treating, the hyperreflexia and the spinal cord dysfunction, get better whether we do an operation from the front or whether we do an operation from the back. And so for 50 years in the field of orthopedics and in neurosurgery, we kind of debate this at meetings. But from our perspective, we think all of our patients are doing well. When you look at this from a patient perspective, however, there's something different. If you look at that first plot on the ventral side, you see that patients get 10 points of improvement in their quality of life versus 5 points of improvement with the posterior cervical fusion. That is a meaningful difference for patients. And that, it turns out, determines whether someone goes back to work, whether someone goes back to sports, whether someone returns to the life that they were hoping to return to. So again, think back to that patient-doctor relationship. Our obligation is to do the best that we can do for that individual patient in front of us. So I wanted to look at this in a little bit more detail. One of our residents evaluated the amount of neck pain that patients have with this posterior cervical fusion. And it turns out that when you look at people 3 months, 6 months, a year, I think this publication looks at a year, but we follow these patients out for 2 years, they have an ongoing neck pain that they didn't have before. Okay? So we asked ourselves, why might that be? It turns out that when you look at the data on this, that oftentimes when we place patients for surgery prone, we bend their neck forward because they have a neck crease, and we put their neck in an abnormal position, which is bent forward, and we fuse them in place. So we fix the spinal cord compression, but we've created a new problem that causes lifelong pain. And if you look at the amount of malalignment, you can build a model to show how much it's going to affect their quality of life. So important stuff to do. We wanted to take this a little bit further and say, if we're really trying to understand what's best for our patients, we need to have a mechanism by which we can do what is the best way to analyze things in medicine, which is to do a randomized controlled trial. Okay? So we set out a goal of looking at ventral surgery and posterior surgery with a randomized controlled trial. And one of the things that's wonderful about being in Bermuda is the opportunity to interact with people outside of your environment. And one of the things that I learned and was humbled by is that we had gotten funding from the NIH to do a trial in North America to compare anterior fusion and posterior fusion. And I presented this in Europe. And the European, both orthopedic neurosurgeons and neurosurgeons said, you know, with all due respect, in Europe, we do laminoplasty for this disease. We don't do anterior fusion and posterior fusion. We do 50% or more of the cases as the laminoplasty. So I went back to the NIH and to PCORI, and even though we were funded to proceed, gave them this information, and we adjusted the protocol for the trial to include laminoplasty. Okay. Again, the spirit of trying to do what's right for the patients. Now, one of the challenges that we had was, as you can well imagine, if you sit down with a patient and they have their trust in you, and you say to them, well, I want to put you in a clinical trial, and you're not in a clinical trial to get a new treatment that's not available, but I want to compare two treatments that are available, they look at you and they're not quite so sure. They kind of lose confidence. And they say, well, if you're not sure, maybe another surgeon is more sure. So that was a problem we dealt with. And we had multiple sites engaged, and we wanted to figure out how to deal with this. So it so turns out that one of the people who had been philanthropically very supportive of the research that we were doing sat down and had lunch with me, and we were talking about this, and she said, well, people just don't want to be guinea pigs. Why don't you show them that surgeons across the country in real time differ on the treatment of your disease? So that's what we did. We got our investigators to all look at these cases, and this is where we use digital medical data. We could extract that data and we could send that data to surgeons. And we included people who are not involved in the trial, but who were content leaders, key opinion leaders, and experts. And we asked them the question, is it ethical to randomize a patient into a trial? If this was your patient, is that ethical? And we asked them, what would you do? The idea behind that was to show a patient that if you were treated at the Cleveland Clinic, you would get Operation A. If you were treated at the Mayo Clinic, you'd get Operation C. And if you were treated at Lahey Clinic, you'd get Operation B. So there's chance. And while I was somewhat skeptical about this, it turns out that patients could actually digest this information. And we showed that we could improve patient consent to enrollment in clinical trials and consent to randomization by simply transparently showing patient this information, that there was true, real global variation in care that they could see in real time. So then we had to decide, what are we measuring? So we looked at this and we defined a patient population with the condition of cervical spinal cord compression that we as surgeons, both orthopedic surgeons and neurosurgeons, could understand. We tried to be as inclusive as possible so that what we learned would be generalizable to the patient population. We looked at what we are measuring, and our primary objective was patient-centric outcome. Patient-centric outcome was our highest priority, so we wanted to make that the top thing that we looked at. We wanted to look at opioid usage and utilization, radiology assessment. Are we achieving the goals of surgery that we intended to achieve? We also wanted to consider the stakeholders in our environment. Employers, are we getting patients back to work? And how quickly are we getting patients back to work? Hospital and payers, what are the health associated costs with this? And not just from the traditional inpatient health cost, but one of the things that we learned was that when surgery doesn't go well, that patient costs the healthcare system more and more money over time. Physical therapy, injections, medications, multiple visits back to the medical healthcare system because things are not working out as well. So that post-operative health resource utilization, very important to us. We also, as I mentioned in the beginning, wanted to be accountable. What's the durability of the treatment? Are we seeing reoperations after these treatments? That had to be part of our thinking on this. So we defined our aims with these things in mind. Again, top of the list, patient-reported outcome, a meaningful change in patient-reported outcome being the primary outcome, and then a whole host of secondary outcomes that I've defined. So we did the trial. We saw that the baseline characteristics for patients with anterior fusion, posterior fusion, and laminoplasty were comparable. That was obviously important. The randomization worked. And then we looked at our central question, front versus back surgery. No difference. But I show you this mountain plot here so that you can you can see that some of the people that we treat got worse. Okay, and you see that on both sides, whether they had anterior surgery or posterior surgery. That's an opportunity for us, and not a lot of us look at that. 16% of people who have surgery are not better. But what you'll notice is in that gray on the dorsal side, that's the laminoplasty, very few people got worse. I think there was one patient who got worse in the laminoplasty cohort. And so if you looked at this from a patient health-related quality of life perspective, you see here quite convincingly that that gray, the laminoplasty, 6 months, 1 year, 2 years, 3 years, 4 years, durable improvement in their health-related quality of life, much more so than we see in the anterior posterior fusion. Okay, so again, from a patient-centric perspective, that is really valuable information. We also saw they have fewer complications. This is something the Europeans have been telling us for years, but we just haven't seen it and measured it in our population. Also, ongoing health resource utilization, much less in the laminoplasty, less radiology utilization because they're having fewer complaints, less opioid utilization, and less ongoing physical therapy. All of the things that we know are important and we want to measure after surgery. Doing a formal cost analysis, I mentioned Rob Whitmore runs our surgical program. He really led this cost effectiveness effort. And like what the rest of the world has been showing for years, laminoplasty costs less with greater improvements in health-related quality of life. And so we were also able to look at the data and show that this posterior fusion, which I mentioned at the beginning, which was associated with neck pain, is also costly because patients stay in the hospital longer, they have greater ongoing health resource utilization, and they don't do as well. And so as we think about this as surgeons, that probably should be lower on our priority scale for what to recommend to patients if they have otherwise a condition that can be treated with laminoplasty or with anterior fusion. We looked at return to work data. At 1 month, you'll see that over half of the patients treated with laminoplasty get back to work. And they get back to work full time, compared with a much lower percentage in the anterior and posterior fusion cohorts. Another important thing. So we draw some conclusions from this. Fewer complications associated with laminoplasty, less outpatient health resource utilization, greater improvement in health-related quality of life, 1 year, 2 years, 3 years, and 4 years out of that. So some important things that we were able to achieve by really focusing in on patient-reported outcome as we did a clinical trial. Now I'm going to switch gears for a second because not every medical problem that we see can be analyzed with a randomized controlled trial. I think we can all agree on that. So registries have a very, very important function and role in our medical society. And I want to just highlight Fred Resnick, who's our chair of cardiology, did a study that was published in the New England Journal of Medicine looking at stent safety and vascular access safety. And he found that by using large registries, that you could demonstrate differences in vascular access devices. And here's a publication in JAMA in stent MI complication rates. So with that theme in mind, the spine world is not as sophisticated as the cardiology world today, but will be. We thought, let's take a look at cervical spine disorders with an organized society of orthopedic surgeons and neurosurgeons, the Cervical Spine Research Society, and develop a registry. And develop a registry for some of the most common things that we treat, cervical myelopathy and radiculopathy, 160,000 of these operations per year. And our concept here is to capture data from the electronic health record, so we're not talking about hiring a lot of FTEs to extract this data for us, but importantly also include imaging data. And it was a great start for this evening to hear about the cervical spine CT data. Imaging data is critical to understanding the things that we're treating as surgeons. So we wanted to have a way of incorporating that into our registry in a simple, easy fashion for various medical centers. So we've done that. Turns out that the FDA is very interested in post-marketing surveillance of medical devices, and they have been very engaged with the Cervical Spine Research Society to provide that data to them, and that's generated a funding stream for the society to continue their registry. So that's just been fortuitous. And we've also believed that some of the science that we did with the randomized controlled trial is going to now be available to future investigators by collecting this data in an organized fashion that people can go back and analyze going forward. So I think that there's some exciting things that the use of data collection allows us to do. We talk about predictive models in medicine, and predictive analytics using registries will get more sophisticated as the data that we feed these registries becomes more organized and more structured. We know, for the most part, the information that we know is valuable and useful, and getting that data from multiple sites together will allow us to build some models that are probably going to be better than what we have today. We also want to know what are the sorts of things in which patients cause complications. This is the type of thing that predictive analytics using registries will allow us to do. Who's going to have better outcomes? And ultimately, and I think that will be important for all hospitals, do particular providers generate superior risk-adjusted outcomes? And the ability for us to measure this is obviously going to be very attractive to patients, but it'll also be attractive to payers. It'll also be attractive to employers, all of whom are interested in seeing the best possible outcomes. So I'm going to ask you a what-if question. I started with a randomized controlled trial, and that was interesting to me and important to me on a disease that I thought was important and interesting. But again, it's not the solution to everything that we see in medicine. So what if we could design a study that appreciates that not all patients are the same? And as much as we try to classify certain things that we treat, we can't classify all diseases in a precise way that allows that type of patient to be randomized into a trial. There's an inherent mixture of patients that we see, whether it's the radiology, whether it's the mental health, whether it's the soft tissue envelope. There's a whole host of things that come into play when we're looking at a diagnosis. So I want to introduce that concept to you for lower spine disorders. I mentioned at the beginning we spent a lot of money on lower spine disorders. Spinal fusion is a very, very popular operation which is being utilized more and more. 500,000 lumbar spinal fusions done in the United States now. And the costs associated with this are so staggering that they are becoming something that is almost unsustainable as our society gets older. We estimate that we spend about $35,000, and this is a very conservative estimate, true hospital costs for a fusion versus $12,000 for a decompression, for example. Our government payers, Medicare, are very interested in trying to get value-based approaches to the fusions that we do with this TEAMS model, looking at readmissions, looking at the complications that we see from the surgeries that we do, as well as the costs. And that's going to help us in significant ways. But I want to look at one problem, which causes back pain, which can be disabling to millions of people, lumbar spondylolisthesis. And if we look at how we treat this condition in the United States, we treat about 90% of these patients with a fusion and 10% of these patients with a decompression, okay? So we spend about $5 billion in hospital costs on this disease. And I mentioned a few minutes ago that the Europeans did laminoplasty as opposed to anterior-posterior fusion. So if we look at Europe, and not that we should practice in this way, but in Europe, they fuse 30% of the patients with this disease. And mind you, it's the same disease, okay? If we did that in the United States, that would be $2 billion of cost savings, okay? So naturally, that gets the attention of various stakeholders. And it's not surprising that people have done studies that have achieved fairly high profile. I was involved in one of these, but randomized trials have their limitations. There's a study from Europe on grade 1 spondylolisthesis, randomized controlled trial, excellent study design, no difference whether you do a fusion or not. I was involved in an American study, studied the same problem, and we found a significant advantage for patients with single-level disease and spondylolisthesis with a fusion. So we say this is the gold standard in medicine, but now you have two gold standards, New England Journal of Medicine level work, two different conclusions. So the Norwegians followed up a study and used the patient population that we'd used in the United States, because one of the concerns was that the European study initially that was done had a very heterogeneous group of patients. So they decided to focus on single level disease, as we had done, and do the same randomized study. No difference. Okay? So people looked at that and said, now where do we go from here? You know, we're supposed to do randomized controlled trials. It's hard to reconcile this. Some people felt like, well, Americans are just more obese. And maybe Americans, when we look at this disease, are just more likely to become unstable after surgery, and then therefore require fusion. But if we look at this carefully, we see that the patients that were actually enrolled in these trials had an average BMI of about 27, whether they're from Europe or whether they're in the United States. And that's one of the criticisms of randomized controlled studies, is that we carefully select patients for these trials. But one thing that was consistent in all three of these trials was the failure rate. And you might say, okay, well, if the failure rate was the same, how come the conclusions were different? Well, it turns out that, again, this is coming down to looking at how the study is designed and how the pre-specified analysis was done. And this is not a criticism of any group or whatnot, but the approach in Europe was to say, if you had a reoperation, then that muddies the waters, and that shouldn't be included in the analysis. And so the European studies did not include failures in the analysis. And it was well-intentioned to try to get the analysis to be clean. But if you think about it as a doctor and a patient, a failure is a failure, right? And to not incorporate that in the analysis is a problem. I think that when you try to unify all of these studies, one of the things that you come up with is that there's a predictable rate of failure after a decompression. And it turns out in the study that we were involved in, it was a 30% rate of failure. But if you look at the 70% of people at 5 years who didn't fail, they did great. And they were identical to the patients who had a fusion. So again, we're trying to do what's best for patients. And so we ultimately need to focus on the individual patient. We need to be able to figure out better who is that patient in the 30% category that's unstable and who's not. And that's not easy to do. And that's where I think that some of the technologies that we're just starting to learn how to use, some of these machine learning technologies can help us understand some of these more complex patterns. So we've got another study that helps us try to understand how to classify patients as stable versus unstable. You can see here that people come with all sizes and shapes with spondylolisthesis, and where your spine is curved, what your disc heights are, what the level of degeneration is, are all things that are probably predictive in stable versus unstable. So we've set this up and gotten this funded to be a non-randomized collection of patients where we have a group of experts look at every case, this time not to try to establish equipoise for a clinical trial, but to say what they would do in these cases. So bear with me for a second. The idea here was to say, if a group of experts, if a group of doctors with a certain level of experience see the same thing in a case, there probably is some pattern there. And we just don't know exactly what that pattern is. But what we first started to do is to look at this and say, if a group of doctors look at a case and say it's unstable, and the patient has a fusion, those patients have fewer reoperations and better outcomes. We just published this last year. And this is the initial substrate that we're using with our machine learning colleagues to say, we as human experts see something as a crowd. This crowd wisdom has some meaning. Can our machine learning experts work with these data and help us understand better what it is that we're seeing? And our hope is that we'll ultimately reduce variation in care by taking this kind of approach. So I promised Dr. Brown that I would also include, what's new in spine care. And so we've talked about how we try to get new information with spondylolisthesis, with cervical myelopathy, but there are today some new things, particularly in the non-operative side, that I wanted you all to be aware of. And I wanted to show you another individual in our program, Dr. Cletus Chayu, who's a functional neurosurgeon, who's looking at some of the modern ways in which we use stimulation to help improve people with back pain, stimulating muscle, stimulating or causing modulation of spinal cord signals in spinal cord stimulation to reduce the sensation of pain that people are living with to improve their overall quality of life. And also, very new, and what Dr. Brenda Lee brings to our program, this basiovertebral nerve ablation, which is the concept that there are a whole host of structural mechanical problems that cause pressure on the bone. And sometimes we as surgeons or as interventional spine specialists, we just don't have a solution for that. But this new technique allows for the nerve inside the bone to be ablated and reduce the pain that patients feel from that compression of the bone. And it turns out in prospective and randomized studies to be beneficial to a significant number of patients who are suffering from debilitating back pain, including patients who've had 1 or 2 or 3 surgeries who've not succeeded in getting rid of their back pain. So I'm very optimistic for the future. I want to also mention that, we need to be rigorous as we introduce these new technologies at Lahey or anywhere for that matter. So the registry, the collection of patient-reported outcomes to continuously evaluate and reevaluate what we do and what's working is going to be critical to our success. So to summarize, just a few concepts for all of you. First of all, it's really been a pleasure to be here with all of you, but modern spine centers are collaborative, and I think that's the way forward. We have to work together. I think Lahey is a great model for that, to learn from each other and to treat patients together. Optimizing triage at a systematic level to get the right patient to the right doctor ultimately drives efficiency and lowers costs, and also enables greater cooperation of the team. Registries help us establish clinical benchmarks. We can understand from doing registries what should we expect a patient's success rate to be from this surgery, and if we're falling off from that, we need to ask ourselves why. Our data collection is also understanding or helping us understand what works in what patients, especially as we introduce these new technologies, and we're going to be very committed to that going forward. And we're going to be very mindful of cost. Some of these technologies cost more money, and we need to look at the cost effectiveness of what we're doing, and the costs of these implants, the costs of these technologies, so that we can lower ultimately the cost of care. And in closing, I thought it would just be worthwhile, since we're a group of physicians here in one room. Sometimes I hear from my colleagues that, I want to go back to the old days. I want to go back to where it was just me and my patient, and I could decide what should be done. I could prescribe what operation I wanted to do, and I didn't have to deal with the insurance companies, and I didn't have to deal with the hospital and the administrators and so forth. Well, that day's gone. But that's not the end of the world, and what I hope I can show you is that there are a lot of technologies, crowd wisdom, learning from each other, registry data collection, randomized controlled trials when appropriate, the use of artificial intelligence and machine learning that's physician-driven by collecting structured data so that we're understanding what problems we're trying to figure out, that are going to ultimately help us to advance individual patient care, which is where I started. And I think that's where we all want to be. And again, thank you so much for allowing me to be here this evening. Thank you, Dr. Brown. Thanks, Dr. Moffat-Chris.
I think you all would agree that that round of applause was not the one you really meant. On behalf of the Bermuda Healthcare Services team and everyone in the room and those physicians who couldn't be here tonight, I'd like to thank you, Doc, for coming down and sharing your wisdom. Thank you.
Thank you. It's a real pleasure.